I'm Steve. I'm a ITU consultant here at Barts, and I'm also one of the ECMO team here. And I spend a proportion of my time bossing new people around from a distance, making jokes, and sometimes trying to be clinical. So hopefully this won't be too much of a stretch. The idea behind this is really I just wanted to talk through it really more than anything else. So if I go through what some kind of general principles are, and then I appreciate that both of these things are pretty uncommon, but also stuff that is quite niche. So if you have particular questions or I've pitched at the wrong level, please just shout. I'd rather just kind of, and I'm also aware that there's a spectrum of experience with both of these bits, because so the first one we're going to start with is prone transfers. So basically, what I'm hoping to cover is why on earth you would want to transfer a patient on their front, a bit about when to do it, and importantly, when not to do it, and then some general principles about how you do it, and then whether it's safe, bearing in mind that both of these are relatively evidence-free zones if you go looking. Well, proning is not evidence-free, but certainly putting them in the back of an ambulance is. So I'm hoping, however, that most of you have some ICU background, and therefore I don't need to convince you that proning is an effective and well validated treatment for the management of severe respiratory acute failure, particularly infective. And hopefully I don't need to convince you that actually you might need to move people who've got severe respiratory failure around for either capacity or clinical reasons. Now, prior to COVID-19, this wasn't a thing, right? Nobody got moved on their front because everyone thought, why the fuck would you ever do that? And I think if COVID-19 taught us anything, it's that you can do quite a lot people upside down, and actually it's still quite safe. We did a lot of this actually in makeshift ITUs, or it felt like makeshift ITUs. We did a lot of this in people who were pretty unstable hemodynamically. We did a lot of this with people who were attached to various machines that previously we might have gone, fuck, we're never even going to consider this. And also, it probably is worth pointing out that when you're going to do these moves, although the ECMO service across the country is pretty well established, not everybody has retrieval capacity, and not everybody can be retrieved by an ECMO centre in a reasonable period of time. And we are pretty well served by that within London, but the rest of the country is not. And particularly if you get up to some areas in Scotland and indeed the northwest, where actually you're talking about a 3 or 4 hour journey before you get access. It's also worth pointing out that actually people who are retrieved by an ECMO service is one thing, but there will be a relatively high proportion of people who are not candidates for ECMO retrieval. And that may be because of comorbidity, that may be people who are people who are too sick, people who are unfortunately at the extremes of an age limit, or who've been ventilated for too long. Those are the main reasons. But yet you might need to move those patients in order to make capacity for other things, or indeed they may have other needs which can be managed, and that is entirely reasonable. Okay. So those are the general kind of reasons why you might think about doing this. There are some risks, and these are the ones that everyone used to kind of quote. So you pull the tube out is the main worry. We're going to assume that most of these people are actually on their face because their lungs are pretty poor. So actually an accidental extubation may be particularly problematic for them. It's also quite hard to intubate somebody on their front. It's not impossible, but it's not something that we're trained in. We are used to people being on their back with equipment is designed for that approach. It's quite hard to do effective CPR face down. It's not impossible. We'll talk a bit about that later. But being able to do sternal compression is obviously not going to happen. So you're going to need to use their spine. And actually, in most ambulance settings, your 360-degree access is pretty limited. And if you think about what we all hopefully did or were familiar with in proning, it involves people on both sides, right? So unless you're in an ambulance where you have access both sides, and that is not all of them, even the bigger ambulances, people tend to be more to one side or the other, it can be quite difficult. And if you start taking people who are prone on flight, most of those people are up against a wall because of the needs of the other bits of equipment that need to be secured or have access to. Importantly, most of the time we have access, but it can be difficult to get to lines, which means that and other things are a challenge. There are hemodynamic effects definitely to turning. Actually, if you're a bit empty and you flip people, then you can become quite hypotensive. You also run the risk of kinking or loss or disconnection of vasoactive infusion, which obviously has some pretty significant consequences. And therefore, actually, but if you think about what we did in COVID, actually we were proning people on quite large amounts of constrictor, where a few years ago we wouldn't actually have even considered that. If someone was on more than one vasoactive, I don't think we would have proned them 10 years ago. We would have probably think that was too unstable. Obviously there are concerns related to pressure area care, so on ICU, on an inflatable mattress where you have access to specialist kind of facial packaging or kind of gel pads and all of the other things. Hello. Then actually that's great, but in the back of an ambulance you don't really have that option. You have what you have, and we all know what the trolleys look like. You can get bariatric ambulances which have more space. You can use gel padding and vac packs to try and do things, but they're not perfect, and they're certainly not as good as an ICU bed. And displacement of other lines, tubes and drains which the patient may well come with or indeed need is also a risk. The other thing to say is you have to plan what you're going to do if you are potentially going to need to intervene in an emergency. And most things that you are going to do in an emergency, one of the first things you're going to need to do is you're going to get them back on their back. All right, so if that tube comes out, if that line gets displaced, trying to recite those things face down is harder. And we all know that space is at a premium, staff are at a premium, and in the back of an ambulance, you're going to need, you just have fewer staff. And if you think about some of the patients that we move, particularly some of the larger people, we know as well that actually if you are trying to prone somebody in ICU, you're talking about 7 people for most of the time, 3 either side and 1 for the tube. Sometimes you might need more, because if you've got filters attached or you've got particularly large people, then actually you just need manpower, and we just can't carry that. You can potentially get an additional staff to come with you, but probably not in the back of the truck, and that again needs consideration. Stop me at any point if I say anything that you want to do. I'm just going to get rid of WhatsApp because it'll just beep. All right. So, what should you think about before you start to think about moving somebody prone? So the first question is, have you got enough people? So our SOP is that within Access is that all prone moves are consultant escort. And that's not just about the fact that these patients are sick. It's about the fact that you probably need 2 physicians, and you're going to need a senior airway person, because actually if you do have to reintubate this person, it's going to need some skill and some manpower. Now, if you go looking at the literature for this, there are some pretty big ECMO centres in North America, particularly ones in New York. When we're talking big case series, most of the case series of this kind of stuff is like at most 100 patients over a 5-year period, or 25 patients in the kind of space of COVID. And bearing in mind that nobody publishes when they fuck it up. So they probably haven't told you about the ones where it went wrong, or it just hasn't been collated, right? So, but they have described paramedic as kind of escorted. Ontario as well, it's a big distance. They didn't have physicians to spare during COVID, so they sent ICU nurses with critical care paramedics who had some basic airway skills, some ventilator skills. But our model is going to be physician, and I think that is probably unlikely to change. Although Esther, you'd be fine. So the thing is the question: are you proning them to get them somewhere? I.e., are they already proned, or have you arrived at a bed space to find someone where they're coping on 80 or 90% oxygen, but actually you're going to need to do what is probably a capacity move? Now we've had this. since we started. We had a patient in a private institution who essentially needed to be moved, not just for capacity reasons, but actually she was in the wrong place, right? So this, although they weren't necessarily going to do an awful lot different, but this lady was in her 80s. She'd had a hip replacement privately. She'd aspirated. It was all very bad, but she wasn't really safe to stay where she was. So although it's dressed up as a, this is no longer a thing, they're not going to do anything different, actually you do need to get that patient safely. And that patient wasn't prone because they didn't feel comfortable to do so. It wasn't what they did, wasn't their normal skill set. And we all work in NHS hospitals in the main. We're familiar with this, but you have to remember that not that long ago, certainly in the SRF centres, we would get referrals from people who were unhappy to prone because they weren't happy looking after the patients. Now, the pandemic changed that, but it does, you have to have a think about how you're going to do this. And it's difficult to legislate for that because actually it does depend completely upon the patient, the distance, and why you're moving. And I think those are the other key points. You need a bit of a team brief, unsurprisingly. Again, I think that's important to be focused on the clinical handover, not worry too necessarily much, not worry, not to put too much emphasis on the fact that they're face down. They may well have other problems. You don't want to miss those. The bleeding problems, the lines that were difficult to get in, the unstable fractures or other bits and pieces. People have other things going on, and it's important to be thorough in your assessment and take your time. These are not quick things. Okay, this is going to be usually a short distance and usually most of the kind of session, if you like, be it morning or afternoon, because these people are not ones to rush. If you're talking about a rapid clinical move in somebody who is prone for some other problem, then that is a consultant level discussion, as in us with the referrer, about is this doable? And not everything is, and that is also worth bearing in mind. Allocate tasks for packaging, and I think this is one of the ones that I would strongly advocate, that it should be slow and together. Take an ABCD approach, do things kind of sequentially, but don't rely on other people to have done things. And I know there can be a tendency to want to do that. You want to let other people double pump, or you might kind of wean or prepare stuff. We've all seen it. We all know what happens. It's just careful and kind of together, and make sure that everything is everyone has got given a particular role. Because the other thing is, you're going to need to reverse that. So at the end, you're going to need to unpackage, if you like, and it makes therefore sense that if someone has done something at the beginning, that they do it again. Also, if you're talking about, who's connecting or who's moving ventilators, who's moving infusion pumps, in an emergency, when you're going to have to get the patient out, and we'll talk much about that, you need to understand who's going to do that again, so that you don't both try and do the same thing. So my advice to you is stone together at each stage, identify who is going to do the ventilator, who is going to look at kind of lines or etc., and then do it. The other thing is, you're going to need to have a full sheet underneath the patient for the whole time in order to depro. Okay, because you can't, we all know what the back ambulance is like. You can't roll them from both sides to get a slide sheet under. Yeah. And also, if you're deproning, you're not going to be deproning in the back of an ambulance. You're going to have to get out into the external environment. It may be dark, it may be wet, it may be the side of the road. It may limit the amount of time that you're going to need to do, limit the amount of time you have available to do something. So trying to have the option to deprone quickly is important. And I'll talk about a way that you can do that. Right. So some general guidance. So I go through this kind of in a relatively square. I haven't gone ABCD. I've just gone. It makes more sense to me. Right. So the first thing, obviously, the tube is tied. Take off the I've forgotten the name, Anchor Fast or whatever else they've gone. Melbourne strapping. Everyone heard of Melbourne strapping? To remind what Melbourne strapping is. Melbourne strapping is the fact like tape. So tape with the spins, and it goes up and around each side of the mouth. Okay. you should, in theory, be able to like lift it and it not move. Okay, and so you need proper brown stretchy tape, not the crappy stuff. The classic Melbourne strapping is you also tie it and you have a suture around the tube as well. But actually, that's what. So it needs to be taped with brown stretchy tape in the middle, on the side, in the middle of the mouth, and it needs to be done so that you can turn the head and it's not going to kick. Okay. All invasive lines of any kind get stitched. I mean, that includes cannulas. Okay, things get wet, things get disconnected. If they get disconnected, they also then get wet. The dressing gets, you do not want to be scratching around trying to sort that out in a rush. And you need to think about your positioning of where things are going to go when you spin. And also, I'm going to assume for most of the rest of this talk that actually the patient is already face down. Okay, so you've proned them on the bed, and I would advise you to, we'll talk about how you move across, but the patient should be probably face down on the bed, and you slide across face down, then you try and do it on the trolley. Okay. So you need to be able to spin on an axis, potentially, but that means that all of your infusion pumps lines need to come towards the top before you move across, and all of your catheters, drainage bags, other things need to go towards the bottom so that they're not going to get caught. And remove inline suction catheters because there is a risk of disconnection or kind of pulling as you go. Now that's again a bit different to what we normally do. You may or may not be able to get access to it, but that means you also are going to need spare suction, bronchial suction catheters. They need to be asleep. They need to be paralyzed, and I would suggest that long-acting drugs are important. It may well require you from rationalizing some of the infusions. These people may be on a fair number of things. They might be on sedatives, might be on vasoactives, might be on heparin, maybe on other kind of stuff that you can probably manage as boluses. So you need to kind of have a think about that and what your options are, both in terms of what access you have, also what drugs are available. And the thing, hopefully this isn't the surprise, you want to try and optimize the ventilation as much as possible before you move and before you leave. Now, it is probably pragmatic to transfer them on the IT ventilator onto the trolley, and then having transferred them and made sure they're stable on the ventilator that they're on, to then switch over to the Hamilton or your transport ventilator. But let's say for the sake of transport. And that is probably because you want them to be as good as they can before you move, and then as good as they can before you fiddle with another vent. That makes sense. So if you're already on something that is sort of managing, and I'm going to kind of preface that they might not be, but let's use something that is currently working and then add an extra variable in, rather than move them and having added kind of event. If you can't do that for whatever reason, so let's say that your oxygen hoses don't reach wall ports, let's say that you've got problems with positioning or access, then put them on the Hamilton prone and sit on the Hamilton for however long it takes for you to feel comfortable that you haven't got them as good as they can. Okay, and that might be an hour. That's fine. Okay. Usually these people will have had some attempts at recruitment, either be it recruitment maneuvers or kind of manual recruitment through the vent before you move them. If you could manage without, you would probably be moving them. But it is worth trying again yourself and in cohort with the consultant who's with you, because it might actually help. Think about your positioning of monitoring and defibrillator pads if you think they need. You're not going to be able to get them on very easily in transit. So if you think you might need defibrillation, and I think my threshold for this is virtually nil, so a bit of AF previously is enough for me to put pads on, then I think that is an easy win and very, like what's the harm, right? So I basically put pads on virtually all of them. And then think about your order of transition. So what I would suggest is keep them on the regular vent, pumps and stuff to the top, catheter and stuff at the bottom, monitoring on the Philips, because actually it's usually easier to go across with the monitoring on. But you need to, again, that monitoring needs to be established completely and you're happy before you move. Any questions so far? Any questions from the group? I never asked if anyone had done any prone moves. No. Packaging, just bear in mind that things will be the wrong way around and you might need to think about where you put stuff. So this is one of the Ontario groups suggestions, because then they can get access to the defib. So you might need to think about positioning things in a slightly different place. It's worth thinking about what you would do if they came off. I'll show you, talk about that in the other one, but I tegaderm a lot of this stuff down because it doesn't come off, right? Everyone knows tegaderms are heat activated. So if you put it over the top, hold your hand over it for 10 seconds, all the dog ears will sit down. Revelation. It works with stomas as well. Yeah. Yeah. It's actually quite sticky. Yeah. Yeah. Okay, so you've got your patient positioned with everything ready to go. You've made sure that you've got enough slack. You've made sure that you've got enough drugs. You've made sure they're as good as you can get before you move. You get sure that you're going to paralyze them, and you now need to get them onto the stretcher. Hopefully it's not controversial to say that you absolutely have to have a slide board and a slide sheet, but importantly, you need to put the slide sheet under the patient, because you need to arrange the sheet that's going to be on the stretcher in such a way that they're going to land with it a bit like this. So if you see the kind of arrangement, you want 2/3 of your sheet to the side that's towards you so that they end up in the right place. So you need to spend a bit of time positioning the sheet on the trolley so that you've got enough space, enough overhang on the left, but also enough to wrap them in. Okay. And you're going to need to roll that enough space. That the idea behind that is that you can keep it rolled up next to you, so you can throw it over the top to spin them. So you can't put a second sheet in donuts. You also need a slightly longer sheet. And you probably want to move I take the pillow out from under the head, but try and keep the pillows under the pelvis, the chin, and the shins. And that's partly because you're going to need to then I'll show you can change it to a kind of coiled up towel, but you run the risk of it getting caught and stuff getting pulled. So what do? You need to practice this bit. Moving on to the stretcher. So the most senior person holds the tube. You hopefully are going to have more than two, but at least two people either side of the patient. Put them onto 100%. Slide to the edge of the bed and stop. Check you've not got any tension on any tube, any device, or any monitor, and then complete the move. This assumes that you don't really have people to help, but I think I would anticipate that your referring hospital, and indeed your receiving hospital, might be able to help you slide onto the stretcher, but let's see. But you need a minimum of two. So once they're on, you need to think about your positioning of the patient. So in ICU, we will usually want to think about head turns and arm support. In the back of an ambulance, I don't think that holds. So what I would want to see is the patient's tube the whole time, because I think if you turn it to the way from the wall, so for us, that means turning the head to the left, okay, and arms up, because it's very difficult to wrap with the arms by the side or do that. So there's not really a good option, right? So you can have it like that, where you can not really see, or you can have it by the side, which is a bit uncomfortable and you might not go. But in general, arms up. Again, I don't think you can be too didactic of it, because it does depend a bit upon the patient. If they haven't got much ability, if they're really large breasts and or kind of man boobs, then being able to splint them forward can be a bit of a challenge. But you want to be able to see the tube. You're going to move across. You want to, first of all, confirm your tube position. So the usual stuff. Have you got end tidal? Are you ventilating appropriately? Are your IV lines and tubings intact? And then firstly, reset the FiO2. And then you think about your padding. So the best way to do this is to get a towel, roll it into a tube, and then turn it into a C, if that makes sense. And then turn the head so that the tube is out of the C. A bit like most, you do this in ICU, so it's hopefully not that unfamiliar. And place it in such a way that you are hopefully not compressing the eyes or any other kind of important bits. Check the pelvis and the shoulders. Check that the genitalia isn't being compressed, because hopefully you're only going a short distance. Well, you should only be going a short distance. That's one of the other kind of things I haven't talked about. But there isn't really a distance limit. If again, people have published flying for 4 or 5 hours in rural Canada because they've had no choice. So, we are again lucky because we're usually going to be moving not very far, but and then your turning sheet would go, well, I should say, left side of the patient. Big problem. So essentially, you roll it up so that it's next to you. Make sense?
Yes, you might.
Yeah, but it's like you can't really cornish pasty it, but it's like cornish pasty this. Yes, exactly. And then and then strap them in. They will still work. You'll be able to go over the shoulders. You'll be able to go either side. Monitoring over the top. IV line accessible. I would have a pretty if you got a central line with no which on the other side, I would put in either an extension, so the port, so that you can get an extra three-way tap and a short extension or something along those lines, just so that you're going to be able to get to it easily. Because again, the central line that side, you're going to be struggling to get to it in a rush for bolus drugs. Okay. Right. So, before you leave, so you've done that. You're gonna gently go to the ambulance. You're gonna go there nice and slow with plenty of people, considering also the other bits of how much oxygen you've got, how far you got to go. Do you know where you are going? Have you got contact details? And what is the expected response at the other end? But hopefully those, much like any other referral, you've sorted, or someone has sorted, I reckon. But key points about this, just to talk through, are what is your emergency deproning procedure? I'm going to talk about that in a sec. Have a think about what your unplanned extubation plan is, which may well be get them over on their back and stand, but you can know this is where your thorough assessment comes in. You knew that they were a video laryngoscope before, then you need to work out who's going to open the video laryngoscope out of the bag before you get it. And so just talk through those aspects. Just revise prone CPR placement, so I'll show you that in a second, and then confirm that you can get to both the turning sheet and the bolus line, because those are the things that you're likely to need. En route, we will pre-alert the receiving location, including telling them that the patient's prone and making sure that they have a slide sheet and slide board ready. They may also need additional therapies prepared. So you may be we shouldn't really be doing this in the UK because they will usually be retrieved by the ECMO services. But sometimes, and we have certainly done this in the past 6 months, there isn't capacity because they're all out on retrieval, and we have been asked to take people who are profoundly hypoxic to an ECMO centre because they needed to be cannulated, but they couldn't do it. Okay, and it was a short journey and a rapid turnaround, but a team was waiting to cannulate. They had, additional staff perfusion, all those things. There's no point moving somebody, and that's what I'm saying. You're generally not moving these people in a rush. Why would you do an emergency deprone? So the main worry that we're going to have is it's about extubation. So if they've extubated, then you may as well get rid of the alarm, put the ventilator on standby, and try and manually ventilate. But the important thing that you first need to do is tell the team who are driving. So the ambulance needs to stop, okay? you do no one any favors if you turn one hypoxic person into one hypoxic person and 4 casualties because there's a crash. So the ambulance needs to stop, and you need to get the patient out of the truck. You can basically do nothing else apart from until you've done that, right? Importantly, the ambulance will also therefore need to radio for help because you're going to need more pairs of hands. So you're going to need a frontline response, quick care paramedic, but they need to tell Blue Base. There will be a consultant with you. Hopefully they will have the headspace and time to be able to let the wider team know, but actually you generally use the LAS infrastructure. The LAS infrastructure will get you a frontline ambulance and stuff. That's what you need, right? Okay. And again, this is where you need to come back to who did what before. All right, because to unprone them, where are our infusion pumps? They're at the bottom, lines at the top. So you're going to need to get the infusion pumps to the top of the head. Okay, you're not going to have a pole, so you're going to have to put them essentially in whatever is around, so you don't know where you're going to be parked. So you need to work out how you're going to do that, but they do need to go to the top, because if at the bottom you try and spin, you'll probably pull them. So infusions to the head of the bed, probably just on the stack, kind of leaning on the side of or on one of the other poles. You need to get the edges of the ship, the edges of the sheets together over the other side. You need to make sure that nothing is going to be pulled. Cornish pasty them as far as you can, both sides, and then it's the same thing. So it is over, and you turn the head towards the side the face. You turn them towards the side of the face that the patient is facing. So that's probably going to be the left. Okay, because then you have sight of the tube the whole time, and then proceed to manage the airway and the physiology as appropriate. And that will depend upon what the problem is. Actually, you might well be able to sort that out with that. If you think the tube's partially come out, then you might be able to advance it, etc., etc. So just to go through those. So infusions move to the top of the head. Make sure you can see the lines of the tube. Edges together. Cornish pasty to take off the sheet, take off the slack, and then over you go. Clear comms is important here. So again, it's important not only to verbalize what you want to do, and this is where having someone senior at the top end is important. So what you want each member of the team to do is do things together, but also do things all at the same time. Make sense? So how do we all prone on ICU? There's usually a three. Is everybody ready? Is anybody not ready? Okay, we're going to slide, swap hands, rotate. So it's 3 separate commands. Okay, and look, it's your receivership, followership, all that kind of thing. You want people to respond. This kind of stuff is something, therefore, that you have to talk about before you leave. So being able to walk that through in the case of needing to.
Is our people on the top and the vent being on top of them. We trying to pass hands over as you are doing the sort of lower half of the body. Realistically, are you going to need to come up the bed slightly so that actually your head may actually be hanging?
Which is another reason to take the pillow off, so that it's not cool. Yeah, because you do need to come up slightly.
It's all about
yeah.
feet being able to pass the sheet.
Yeah. You may, in all essence, be able to do it in a kind of smooth, all-in-one move. I think it kind of depends a bit on the patient and actually how fat they are. But bearing in mind, this is not the same team member. Now, you may have time to wait for additional staff to arrive. And that's fine. You pull over, you stop, you make a risk assessment of whatever the problem is. If it's actually they're desaturating, but you don't think it's a tube problem, you think it may be a pneumothorax, or you think it may be secretions, or you think it may be hypotension, then actually you might be able to sort some of those things out without deproning. But it is as best to get help to do this on the way. So your threshold for stopping, for asking for LAS for a kind of additional resource should be pretty low. The other question is, if you have a problem on the way, is it better to stay and play, or is it better to keep going? And the short answer is I think that depends a bit on the patient and also the circumstance. And we always have this, right? So you're taking somebody who's unstable. What can you do? Can you immediately do something? Now, you might be able to do something about something. So if it's a kink, if it's a disconnection, if it is let's say the oxygen for some reason has failed and you can therefore need to switch over to a cylinder, those things I would stop and sort out. If, on the other hand, it's someone who is having progressive deterioration in their toxic status, you're satisfied there's no pneumothorax, you're satisfied that it is their underlying disease process and that you're not going to be able to, it may be more appropriate to just keep going, depending upon where you're going to, because you're usually moving them for a reason. And again, this is a conversation that, you know, this is a team decision and discussion amongst probably more than one of the consultant team. I'd expect to be fine. Prone CPR. So you can basically do whatever you want. So there are two options. So you can go directly onto the spine. It's around the kind of base of the scapula. So that should be around the kind of heart level. And you can either go onto the spine or either side of it, but same ratio, same rate. You won't get as much recoil because it's quite hard to do. But it is more effective than nothing. It is not effective as not as effective as supine, but it does offer something. Again, what is happening? What are you going to need to do? Can you keep going? Should you divert? All of those things are going to be. What I would say is actually this. I think for the consultants, this is whilst this is happening, this is one of the things that it's not, one of us will be in the truck, but the other person needs to be not only coordinating your response, but also thinking about what to do, because the people in the back of an ambulance won't have the headspace. So what you should be doing if you are the other consultant is telling them what you have decided, not asking for an opinion in some ways, because they're going to need to resuscitate. And if you think that actually looking at because you may not know who you are, looking at the geography, looking at the distance, the best thing to do is to go to that hospital there, convey that message, get onto that hospital, tell them you are coming, and explain to them what the situation is. And this, we have access to EDs in most, kind of contact details for most EDs. So if you ring, similarly, LAS Frontline have access to that. They can kind of trigger an alert through their own comm system, and then you go. When not to do it. Now, there are no absolute contraindications. I think probably the main reason to not do it is if people are unhappy to do it. And that can be clinical. You might have someone who is pretty unstable. It can be experiential, it can be seniority, it can be actually this just doesn't feel like the right thing to do. I always encourage people to listen to their gut in this kind of situation. But if you are faced with something that you think is going to be difficult, then maybe it's just not the right thing, and the risk benefit is not in their favor. And that again is a discussion with the referrer, because they will want rid of this patient. Yeah, they will want this patient to have gone. But sometimes we've had this again, you can take them prone, or actually you might be able to provide some support about what they can do to make the patient better before you move them. And that again is part of our role, being able to have a discussion and say X, Y, Z. Relative, I mean, difficult intubation. If you think if they needed an awake fiber optic before, it's maybe not sensible to embark upon a long distance move to Portsmouth. Unstable spine, I would hope they're not transferring someone with an unstable spine, but never say never, right? And hemodynamic instability that you can't make better. I think this is the question, because this is a move of last resort, right? This is a we have no other options, and they need to be moved for clinical reasons, generally speaking. Capacity prone with the pandemic thing, I think in this scenario where we are now, we would only be moving patients where there was a definite clinical need to move. A bit like NIV transfers, you know, we do far fewer NIV transfers now, whereas actually in the pandemic it was pretty common, right? And now we kind of have to think about, should we be doing it in a different way? Is it safe? So, as I say, there have been some cohort studies. They report desaturation and hypotension as the major adverse outcomes. These are highly standardized protocols. They are skilled staff who are all critical care trained, and they are a highly selected bunch of patients. So they're not people who are at the extreme. So, you know, who knows? Most of it has been by land, but some of it has been supported by flight. And I think I said that. This is the biggest trial. So it is New York. Were patients who were transferred to a regional ECMO centre over the second wave of the pandemic. They took 115 people prone out of, I think about, I forget exactly, but they had something like 1,500 moves over. Can't remember. It was over. It was like a multi. It was a pretty big. Unsurprisingly, most of them had severe LDS. They weren't moving them very far. 32 minutes median prone transport time. So actually, it's not long distances. Most of it was due to COVID. 60% were moving for ECMO because they didn't offer an ECMO retrieval service. So they were people who were being moved for ECMO. Oh, it's Canadian. That was it. That was it. It was Ontario. This is Ontario. This is Ontario. It's not New York. It's Ontario. It's Ontario. It's Ontario. And basically what they said is this is safe if you're sensible about it. If you look at their adverse events, they're pretty low, to be honest. So, yeah. And with that, any questions? This, but that is a very valid observation, and I think comes back to the point I was saying that actually, if you are a team in that scenario, then actually you need to factor that into your kind of approach to these patients. If you are faced with a scenario that terrifies everyone in the back of the ambulance, that's going to be a difficult move. And then you have to ask yourself about the risk benefit of moving that patient with that bunch of people at that time versus leaving them where they are. Okay. Now, we don't do many of these. Even with the ECMO service, you do very, very few of these. But the ones that we generally move are people who are probably bad but stable, I think is the best description. So they are people who you don't want to leave where they are. They're not people who you would be actively deteriorating, because actually, if they're not on ECLS candidate at that point and it's just pneumonia, they're dying. And we don't move people just because they're dying. Right? So these are people in whom a degree of unpleasant stability has been reached, but they're at the extremes of what that centre can deliver. And you have time. So even if you go, you assess the patient, you get them established position, you get them established on the transport ventilator, and you sit there and you see what happens. And if after an hour they're deteriorating, well, then maybe they're not moving. Yeah. It's just an alternative for certain circumstances that we have available. And I say this all the time, feng shui. What layout is important?
What's the X-ray retrieval on those?
No, we don't. So we have, we're just about to get a new ambulance, but it's Bears. It's slightly wider. It's not actually that much wider. It has internal cameras. It has seats that are in broadly the same place. We currently have a very heavy and quite old trolley, which has pumps underneath. So it has 5 pumps. It has a monotop. So if you have a trolley, pumps, monitor, which is facing this way. We have a servo eye, terrifyingly, on the vent, so like one of the big ICU vents, and the ICU, the screen next to it. At the bottom is a shelf for a balloon pump, and the ECMO circuit goes on a shelf that clips off and on, and that goes onto the top.
Onto the where.
Yes, very, very similar, but it's a little bit higher. and that also has an inverter built into the ECMO, into the trolley, and it has 2 CDs, I think. I can't remember. But it has two oxygen cylinders. We are getting a new one because it is insanely heavy. Yeah. Yeah, I've got a picture. Yeah.
Yeah, I've seen. Huh?
Yeah, so we have had injuries, we've had lots of stuff. Where is the child? So yes, we're getting a new one basically, and that is probably the kind of main challenge related to it, and which is that actually the weight is the rate limiting step. We didn't used to have a winch. So by the time you've added, so has anyone met Rose?
Yeah.
So bear in mind, you're pushing, no one who's skinny needs ECMO. You are pushing probably about 200 kilos between you up a ramp. By the time you've added the inverter, the full oxygen cylinders, 5 pumps, the patient, the cardio help, which we now can't take, and we have to take the Levotronic system, which is heavier, and hopefully not a balloon pump, but sometimes a balloon pump, quite heavy. So yes, it's not the most fun.